Well, good morning, everybody. Welcome to the Symptom Control and Quality of Life Committee meeting. My name is Michael Fish. I'm the co-chair of this committee along with Lynn Henry, and we welcome you.
Hi, everybody. Thanks for joining us.
We're going to let you know about our disclosures here. If you go to the next slide, we'll reveal our disclosures. I'm employed by AIM Specialty Health, which is a subsidiary of Anthem, and I'm also a clinical professor at MD Anderson Cancer Center. And Dr. Henry has research support from her former institution through Pfizer. Next. So this is a preview of what you'll be seeing today in our meeting. We're going to have a special symposium that we'll introduce here at the top of the meeting. The symposium is about aromatase inhibitor therapy toxicity. And then we're going to go over active trial updates. We have 4 active trials and then 2 specific concepts in development that we're going to discuss. And then we'll conclude by focusing on updates from our patient advocate. So we have an ambitious agenda over the next couple hours. Certainly, as we move forward, we are interested to know topics and diseases that you're interested in and specific concepts that you may have. So there's plenty of opportunity to interact with us and be part of our future meetings. Just to remind you that the vision of our committee here is to be the best environment for the development and implementation of clinical trials. And we're particularly interested in mechanisms of symptoms and increasingly interested in toxicity issues as well. We are multidisciplinary and we are strong and very interested in young investigators and working with our strong NCORE network. We have priority topics and methods. We have specific clinical focus and methodologic focuses that you see here on the slide. The clinical focus, chemotherapy-induced neuropathy, immunotherapy toxicity, aromatase inhibitor toxicity, and cancer-related cognitive impairment. So all of those focus areas will be reflected in today's meeting, as well as the methodologic focuses about prospective cohort studies. And we're interested also in digital health interventions and behavioral and integrative medicine interventions. So those are our focus areas, but that does not limit us to exactly those areas. So for those of you who have interest in some other areas that's not seen on this slide, either clinically or methodologically, don't hesitate to bring those ideas forward. We're not stuck exactly on these areas, but this has been our area of focus. Next. And I just wanted to recognize the structure of our committee leadership. Besides the co-chairs, our executive officer is Dr. Gary Lyman. Our statistics team is led by Dr. Joe Unger, with Dr. Rehab Vadia and Celine Jones playing a key role in statistics as well, particularly in patient-reported outcomes. Our patient advocate is Anne-Marie Mercurio, and Amy Gershwinder has been involved as well, but she is not able to participate for this meeting. And our clinical trials project manager is Crystal Miwa, and our protocol coordinator is Mariah Norman. And this team of people, as well as others in SWOG, make all the difference for what happens in our committee. All right, well, that gets us through some of this introductory stuff, and now we get to the meat of our work together. And it is my pleasure to introduce Dr. Lynn Wagner. Dr. Wagner is professor of social sciences and health policy at Wake Forest University. She is a key leader in the ECOG Akron group, where she leads their NCORE research base and co-leads the Cancer Control and Outcomes program. I had the distinct pleasure of working closely with her previously in ECOG Akron, and we are so happy to have her to be our keynote speaker here to discuss the E1Z11 trial. and results in future directions. So Dr. Wagner, thank you for joining us.
Thanks. Thank you for the opportunity to present. And on behalf of my ECOG colleagues and members of the E1Z11 study team, I'm really pleased to share results from this trial and thank Mike Fish and Lynn Henry for the invitation. Next slide. My disclosures are provided here. My consulting work related to PRO research is unrelated to today's presentation. However, in collaborating with Mike Fish for many years through ECOG, I cultivated a great appreciation for the value of sports analogies in the context of cancer clinical trials research. So I disclose my heavy use of sports analogies and my allegiance to the University of Michigan sports teams has positively influenced my perception of Lynn Henry's presentation today as well. Next slide. I'm going to be giving an encore presentation from ASCO of this year on results from the E1Z11 trial, which was presented during this year's ASCO annual meeting by Vered Stearns, the study chair. And Mike Fish, you can see that Mike Fish and Lynn Henry are included as co-authors in recognition of their very valuable contributions to this trial. And Mike contributed to the design and successful opening of this trial. So I would say he served as the starting pitcher and made it through about 8.5 innings. So I guess that makes me the closer. We also are very grateful to Lynn Henry for serving as the SWOG champion for this trial, which really was critical given our ambitious and diverse accrual goals. So this trial, E1C11, is a prospective validation study of genetic predictors of AI musculoskeletal symptoms, AIMS. On to the next slide. Aromatase inhibitors are commonly prescribed as first-line adjuvant therapy for postmenopausal women with early-stage hormone receptor-positive breast cancer and significantly improve recurrence-free and overall survival. Unfortunately, AIMS, AI-related musculoskeletal symptoms are common and frequently lead to early discontinuation, which compromises the effectiveness of therapy and results in women not gaining the maximum benefit from therapy, possibly up to 1/3. Most research has been conducted in majority Caucasian populations, and several predictors for AIMS have been proposed, including single nucleotide polymorphisms, SNPs, in candidate genes. Next slide. So the primary objective of E1Z11 was to validate previously identified associations between 10 specific SNPs and discontinuation of aromatase inhibitor therapy due to AIMS among women with breast cancer. And the 10 SNPs for this trial were previously identified from MA27 and exemestane and letrozole pharmacogenomic trials. Next slide. The schema is shown here. To be eligible, women were required to be postmenopausal and have hormone receptor positive stage 1 to 3 breast cancer, and for whom therapy with an aromatase inhibitor was recommended. We also heavily discussed our eligibility criteria with the design of this trial, and in order to rule out any confounding contributing factors due to comorbid medical conditions or other medications, we required that women have a low pain score at baseline prior to starting AI therapy to be eligible. And we also restricted the use of concomitant chronic medication use for pain. Those women were ineligible as well. The women were enrolled at baseline, completed a history and physical, battery of patient-reported outcomes measures, and provided a blood sample, and then started an aromatase inhibitor, anastrozole, daily. Women were assessed quarterly and completed quarterly visits for 1 year and completed patient-reported outcomes measures at baseline 3, 6, 9, and at 12 months. Women who developed AIMS had an additional visit and an additional PRO battery and were instructed to either continue the AI if possible, take a drug holiday, or discontinue. Those who discontinued their aromatase inhibitor returned 1 month later for a visit and an additional PRO assessment. Our accrual goal included 1,000 women, and we stratified accrual by race to ensure a diverse sample, including 600 white women, 200 Black women, and 200 Asian women. And the patient-reported outcomes measures included the Stanford Health Assessment Questionnaire and PROMIS measures, and were administered either on paper or through Assessment Center, the web-based platform for completing PROMIS measures. Next slide. The trial included a very specific definition of AIMS, which was defined as either a clinician diagnosis of AIMS or 0.2 mean change in the Stanford HAQ, the Health Assessment Questionnaire score from baseline to 12 months. We estimated that AIMS would occur in 40% of women, and treatment discontinuation was defined as discontinuation due to AIMS based on either patient or the clinician ranking. We estimated that 25% of women would discontinue their AI therapy through the course of the 12 months of the trial. Next slide. We had 80% power to detect odds ratios for an effect range for the entire cohort, as well as for each racial cohort. And we assumed minor allele frequency range of 10 to 40%. And as I've mentioned, we assumed a discontinuation rate due to AIMS of 25%. Hardy-Weinberg equilibrium was evaluated in each racial cohort, and details on the Snip analyses are provided here. Next slide. Oh, and also to note, we used a Bonferroni correction for 10 comparisons. And next slide. So this shows our accrual and including timeline for accrual as well as our accrual site. From June 2013 to October of 2018, a total of 1,046 women enrolled in the trial. And this included 640 white, 201 Black, and 205 Asian women with breast cancer. As I mentioned, we stratified accrual by racial cohort, and accrual to each cohort was closed when the target goal was met. This was really critical in order to ensure that we reserved accrual slots for Black and Asian women with breast cancer so that our analyses would be adequately powered by racial cohort. And as you can note here, the white cohort closed to accrual after only 11 months, whereas the Black cohort took over twice as long, 2 years. It took 2 years, despite being only 1/3 of the sample size. And the Asian cohort required a total of 5 years to complete. And I pause here to accentuate this result because earlier this year, in May of this year, I enjoyed participating in the SWOG NCORE Symposium to address disparities in clinical trials. And I look forward to ongoing opportunities to collaborate across our NCORE research bases to improve these metrics for future trials. Also, as noted here, over half of the patients enrolled were recruited from community-based oncology practices through the NCORE network. Next slide. And this slide shows baseline demographics and disease characteristics. I'll highlight a few things. The median age was 63 years. Very few patients were Hispanic. In the total cohort, 73% of women enrolled were overweight or obese, and a higher proportion of Black women were overweight or obese, had received prior taxane therapy, and had a history of diabetes. Next slide. Overall, 43% of women developed AIMS, and 12% discontinued the AI due to AIMS. So that 12% is lower than what we estimated, 25%, although our estimated prevalence of AIMS, 40%, was on target with our results. This slide, these results to me are really striking, particularly the bar graph on the right, which shows that 48 to 50% of Black and Asian patients developed Ames compared to only 38% of Caucasian women. However, if you look at the Ames, the AI discontinuation rate, it's comparable across groups and is in the 12 to 10 to 13% range. Next slide. The primary outcome on looking at the 10 candidate SNPs. Results are shown here. We had a high genotyping success in all cohorts of over 95%. All SNPs satisfied Hardy-Weinberg equilibrium except for TCL1A for AA. For Black patients. Next slide. This table shows the odds ratios and confidence intervals for a SNP association with discontinuation due to Ames, the primary endpoint for the trial. None of the 10 SNPs were associated with AI discontinuation due to Ames, either in the combined sample or in distinct racial cohorts. Next slide. Similarly, none of the 10 SNPs were associated with developing Ames, either in the overall cohort, combined cohort, or in distinct cohorts by race. However, we did observe a strong association between the HTR2A SNP and the development of Ames in the combined cohort. And the next slide provides more details on this association. Our results demonstrated that patients with 2 of the minor AA alleles of the HTR2A SNP, a gene encoding for one of the receptors for serotonin, are more likely to report Ames compared to those with a CC genotype. Patients who had the CC genotype of the HTR2A SNP were less likely to discontinue their aromatase inhibitor compared to those with 1 or 2 of the minor A allele. Next slide. We included in the trial a robust assessment of patient-reported outcomes, and measures are shown here. We measured Ames-related symptoms using the Stanford Health Assessment Questionnaire, physical function using the PROMIS Physical Function Scale, and the FACT-G to assess overall health-related quality of life, as well as the breast cancer and endocrine symptoms subscales to measure breast cancer-specific concerns and endocrine-related symptoms, respectively. We also administered a measure of patient-reported adherence, a measure of anxiety about recurrence, and an assessment of comorbidities, including patient burden by comorbid conditions. And as shown here, we obtained an excellent rate of longitudinal PRO data capture of over 75%. Next slide. So in summary, we completed enrollment to a large prospective diverse cohort of women receiving AI therapy and used strict entry criteria to minimize potential confounders, specifically comorbid conditions or pre-existing pain, which may have confounded our results in evaluating emerging pain due to aromatase inhibitor-related therapy. We also used a strict definition of Ames to be confident in our results that the women who discontinued aromatase inhibitor therapy discontinued due to Ames. The percent of patients who developed Ames in the entire cohort was consistent with our study assumption of around 40%. As I noted already, the percent discontinuing due to anastrozole due to Ames, based on our study definition, was lower than expected. We were unable to validate the 10 candidate SNPs as predictors of Ames or AI discontinuation during 1 year of anastrozole therapy. However, we did observe a trend for an association between the HTR2A and the development of Ames for the combined cohort. Next slide. So to achieve our accrual goal by racial cohort, our timeline was extended by nearly 4 years. However, this did result in sample sizes which allowed us the power to conduct analyses by racial minority cohort, which, as you can see, is a very important part of our results, and important, I think, to understand the how to proceed with intervention. The AI discontinuation rates were similar across racial cohorts, lower than expected, and compared to white patients, Black and Asian patients were more likely to develop AIMS. However, their discontinuation was at the same rate. And this finding that Black women with breast cancer experience a higher side effect burden is consistent with previous research. However, our observation that early discontinuation is comparable across racial cohorts is a new finding. Previous reports have documented higher rates of early discontinuation among Black women with breast cancer. And we look forward to the next several months as we anticipate that our robust PRO data will help us unpack this finding. Next slide. In terms of additional analyses and future directions, we also will expand the SNPs and looking at SNPs that are associated with the development of AIMS as well as discontinuation in the combined cohort and distinct cohort. Since developing this trial, additional candidate SNPs have been identified, which we will explore, as well as other genes and variants, signatures, genome-wide assessment, and genetic ancestry testing. These groups, racial cohorts, were based on race as self-defined. And so we will also explore genetic ancestry testing. Next slide. We, as I mentioned, we have a very robust assessment of many domains of interest in a diverse cohort of patients, which will allow us to further evaluate the epidemiology and clinical predictors of AI discontinuation due to AIMS, and to develop models incorporating patient ratings of treatment burden, fear of recurrence, and other behaviors to better understand a woman's decision to discontinue or continue an anastrozole. And a more refined understanding of contributors by racial cohort will help us to better understand possible contributors to and drivers of disparities and outcomes, as well as will help inform culturally tailored intervention. Next slide. So through Cancer Moonshot funding, the NCI has established a Cancer Treatment Tolerability Consortium, which consists of 4 funded research teams, all focused on employing innovative statistical methodologies to examine clinical trial data sets, adverse events, and patient-reported outcomes data to advance our understanding of the tolerability of cancer treatment. As an important first step, the consortium has agreed upon an operational definition of treatment tolerability using this definition published by Friends of Cancer Research. Based on this definition, tolerability is the degree to which symptomatic and non-symptomatic adverse events affect a patient's ability or desire to adhere to treatment. So in essence, E1Z11 is a treatment tolerability trial and will allow us to explore genetic and PRO predictors of tolerability in this diverse cohort. Next slide. And ECOG-ACRIN is one of the 4 funded research teams participating in the Cancer Treatment Tolerability Consortium. Next slide. Also to give you a foreshadowing of what we'll be doing over the next year. We'll be working on replicating some previous findings with the FACT-GP5 item with the E1Z11 trial data set, as well as others. Prior to the establishing the Cancer Treatment Tolerability Consortium, we reported results demonstrating that the FACT-GP5 item, I am bothered by side effects of treatment, was predictive of early AI discontinuation among women enrolled on the MA27 trial and the quality of life correlative trial E1Z03. The Kaplan-Meier curve shown here shows the probability of continuing AI therapy based on high side effect bother, shown by the blue line. The blue line shows women who reported quite a bit, somewhat quite a bit, or very much bothered by treatment side effects at the time they started their AI, versus the red line, which represents the probability of continuing among women who reported no or little bother by treatment side effects. And with every 1 point increase, on that 5-point scale, a woman's risk of discontinuing early increases by 30%. So as part of the third aim of our Evolve Treatment Tolerability Research Program, we aim to replicate this finding in other ECOG-ACRIN trials. And we've reported some of these results previously at ASCO and ISOQOL from our trials treating leukemia, melanoma, and myeloma. And the E1Z11 trial is the first trial that is similar enough to the E1Z03 to allow us to validate our previous findings. So stay tuned for those results. And the next is my last slide. I wish to close by thanking the ECOG-ACRIN Cancer Research Group, our E1Z11 study team, NCORE site collaborators for enrolling patients, the NCI for funding this research, and the over 1,000 women with breast cancer who enrolled in this trial and generously shared their time, trusted our team with blood samples, and shared their perspective through completing our patient-reported outcomes. Thank you very much.
Well, thank you, Lynn. That was terrific. And I know that there are many questions already popping through on the chat. And we're going to have a little bit of a panel discussion here at the end, but we'll sequence next to our second symposium speaker, our own Dr. Lynn Henry.
Thank you so much. And so I'm the second of the Lynns who's presenting today. One of the reasons why we asked Dr. Wagner to present was because so many people in SWOG enrollment on that study, and we really appreciate everybody's hard work and effort to do that. And also, we were a little afraid with still being virtual that maybe not everyone got to actually see the results of that trial. And so thank you so much for presenting that to us so we can all think and digest what that really means and next steps. So I wanted to sort of one step forward is, can we start to think about what to do to really increase people will be able to continue taking medication, especially endocrine therapy for breast cancer. And so, obviously understanding why people don't take their breast cancer medicine is very important in order to know how to develop these interventions. And so trials like E1Z11 are really important so that we can learn a lot of information. And so I'm going to touch also on another SWOG study that we've done, trying to look at persistence with and adherence to therapy, and then talk about study that we will hopefully be launching in the near future. So next slide, please. As Dr. Wagner already alluded to, and as we all know, adherence and persistence with endocrine therapy over the 5 to 10-year duration can be quite poor. And we know that increases the risk of breast cancer recurrence and mortality. And we know that primarily non-adherence is associated with side effects, but that's not the only reason why people don't continue to take their medication. Things like medication beliefs, socioeconomic factors, essentially race, extremes of age, meaning very young women or very old women, all of this can impact whether or not people are willing to persist with therapy. Next slide. And so a lot of what I'm going to focus on today is actually related to a slightly different patient cohort than what was enrolled into E1Z11. I'm going to focus more on young women with breast cancer because we know from the SOFT and TEXT clinical trials that adding in ovarian function suppression improves disease-free survival in this patient population, whether they take tamoxifen or aromatase inhibitors, in that case, exemestane. But we also know that making people prematurely postmenopausal increases their symptoms and reduces their quality of life, which can make it more difficult for them to continue to take therapy. And actually, in the SOFT and TEXT trial, they documented that 23% of patients stopped their aromatase inhibitor therapy early, mostly because of symptoms. And you can see in the graph here that this was more common in women who were under the age of 35 compared to those who were 35 to about 50. Next slide. So Dr. Hirschman and colleagues previously conducted a clinical trial in SWOG called 1105, which was looking at text messaging for adherence to AI therapy in postmenopausal women. So again, an older population than the SOFT and TEXT trial. Women were already taking a aromatase inhibitor, but they had to have been taking it for less than 2 years, and they had to be planning to take it for at least 3 years and had to have a phone. And so then patients were randomized to either receiving text messages, which were about both taking medication and also breast cancer, twice a week for 3 years. They got it on a weekday and a weekend at a set time, and that was compared to usual care. And then they continued to do their usual clinic follow-up with visits every 3 months, at which time patient-reported outcomes were collected, as well as urine for assessing adherence. Next slide. As you can see here, unfortunately, this showed that whether women got text messaging or not, there was really no change in adherence based on the definitions of adherence that were used in this trial. But we thought of this as a fairly passive interaction. We are sending things out to patients, reminding them about the benefits of taking endocrine therapy and other sort of messaging, but there wasn't this opportunity for interaction with patients. So next slide. So even though this was a so-called negatives trial, we wanted to try to learn from it as much as we could about the experience of patients taking and discontinuing these aromatase inhibitor medications. And so Dr. Hirschman presented this study, which was subsequently published. Next slide. And so in this secondary analysis, what they wanted to look at was what were the factors that were associated with non-adherence among the patients who were enrolled in this trial, and wanted to look at the individual baseline, meaning at time of study entry, patient-reported outcomes and non-adherence using logistic regression, and then wanted to see, could you look at sort of the number of baseline factors that a patient had and predict her likelihood of adhering to or not adhering to endocrine therapy over those 3 years. Next slide. So in this study, the following measures were used. It included the brief pain inventory, looking at joint pain and stiffness. It used the FACT-G to look at endocrine symptoms, beliefs about medication, satisfaction with treatment, and adherence assessment, and then also looked at some insurance and pharmacy issues. Next slide. And here, I realize that this is difficult to see, but if you look at the red bars, those are the ones that were associated with increased odds of non-adherence, and toward the bottom of this slide. And basically, those are all the patient-reported outcomes, whether it was the pain scores, the endocrine symptom scores, the beliefs about medication, those were all associated with increased risk of non-adherence, whereas the socioeconomic factors, demographic factors, things like that were not. Next slide. So then they took that information and categorized patients into how many patients had different numbers of these baseline risk factors. And you can see that, looking at all of them, going from 0 to 14, I mean, there were almost 50% fell into the higher groups, 3 and 4, and more than 20% actually fell into group 4, with 11 to 14 of those baseline factors. Next slide. And then when you looked by group, you can see that with an increasing number of baseline factors, it was an increasing risk of non-adherence, with group 4 having more than threefold risk of being non-adherent compared to the reference group. Next slide. So even though this unidirectional text messaging didn't lead to improved adherence, and we proved once again that non-adherence to aromatase inhibitors is fairly common, we were able to learn something about the characteristics of the patients who were more or less likely to be adherent to therapy. Next slide. So we wanted to sort of take that information, that new knowledge, and then combine it with other information that's out there. So we know that from a number of studies that have been done, that if you just routinely ask patients what their symptoms are, that actually can improve patient-provider communication and improve patient satisfaction. And then Ethan Bosch and others have taken that one step further, doing active symptom monitoring. So what that is frequent assessment of patient symptoms. And it's not just when they come into clinic and fill out some patient-reported outcomes, it's actually frequently assessing even between clinic visits as well. Next slide. So you can see here in a paper that was published in JAMA back in 2017 of a cohort of patients from a single institution with advanced cancer who underwent either symptom monitoring or usual care. It actually showed in the yellow bar that survival in this cohort of patients was improved if they were asked routinely about their symptoms compared to if they were not. And active symptom monitoring has also fairly frequently been used now for monitoring of acute chemotherapy toxicity, getting people to report in, often with IVRS or other systems of what their nausea is and other symptoms that need to be intervened upon during chemotherapy. Next slide. But one of the things that we're proposing to do is take this to a different population. So we wanted to leverage the prior data about aromatase or endocrine therapy symptoms, about endocrine therapy persistence, the data, the information we learned from 1105 and the information we've learned about active symptom monitoring to look at a cohort of young women with breast cancer who are at high risk for recurrence, who are starting treatment with ovarian suppression as part of their regimen to see if we can increase endocrine therapy persistence. And so this is a little bit of a different population from what we've been talking about. Premenopausal, so that is often different stressors in life and things from a postmenopausal population. Importantly, most of the time there are few symptoms attributable to the cancer, and almost all of the toxicity is actually from the treatment. And then also they're not being seen very frequently in clinic. Often it's only every 3 months, whereas there's a lot of time in between clinic visits where people can develop symptoms that can be quite bothersome. Next slide. So our hypothesis is that by using active symptom monitoring in this patient population, we will increase persistence with endocrine therapy. And we'll do that really by increasing patient-provider communication and by reducing toxicity. We are not proposing a study designed to be a symptom management trial. Next slide. And so the primary endpoint will be looking at persistence of endocrine therapy and ovarian function suppression. Secondarily, we want to look at treatment emergent symptoms. We want to look at patient-reported adherence as well as plasma metabolite concentrations to have an objective measure, as was done in the CANTO trial in France. We want to build a risk model similar to what was done for 1105, seeing who is at highest risk for non-persistence with endocrine therapy. And we're also going to be checking some estradiol measurements to see if how that might influence people's symptoms. Next slide. And so it'll include women who are premenopausal at the time of diagnosis. They have to be planning to get concurrent endocrine therapy and ovarian suppression or ablation, and that will mean GnRH agonist therapy. It can mean bilateral salpingo oophorectomy, and it also can be chemotherapy-induced ovarian failure as long as patients and providers are willing to monitor for recovery of ovarian function during treatment, since we know that can happen. And then we're going to allow a little bit of flexibility as to when people can enroll relative to endocrine therapy initiation. Next slide. No prior tamoxifen will be allowed for people who are starting tamoxifen. Similarly, no prior aromatase inhibitor therapy will be allowed for people starting aromatase inhibitor, although they can have had it for fertility. We will not be mandating which drug needs to be used for an individual patient. That will be a patient and provider choice. They will have had to have completed surgery and chemo. They can get concurrent therapies, and it seems like we get new concurrent therapies that people can take by the day. And then they must have internet access, and it'll be open to people who speak Spanish and English. Next slide. So we want it to be very simple. So it'll be women who are either on this active symptom monitoring intervention, which I'll describe on the next slide, plus just getting basic patient information about symptoms and about healthy lifestyle, or patients will be randomized to the patient education information alone. And patients will be seen in clinic every 3 months as per standard of care and complete patient-reported outcomes at that time. So patients on either study arm will complete the same evaluations every 3 months. Next slide. What the folks on the active symptom monitoring intervention arm will do is they will complete 6 questions on their phone or on their computer every week initially, and then every 4 weeks. It'll be just basic joint pain, hot flashes, vaginal dryness, insomnia, sadness, and fatigue. We chose these because many of these can be intervened upon. The responses will go into the ProCore database at UNC. And then if people's threshold answers to those different questions are not above a predefined threshold, then they will just, nothing will happen and they will get their next set of questions the following week. Next slide. If, however, they have results above the threshold, meaning either a change from the time before or something above an absolute threshold, then the clinic will be alerted that the patient has a new symptom, and it will be up to the clinic to contact the patient, find out what's going on, decide if they want to intervene at all or just keep monitoring. And if they want to intervene, it'll be up to them to do whatever intervention they want. So we are not mandating what needs to be done. We're just collecting the information. And really the thought here is that we're just trying to help facilitate patient-provider interaction in between clinic visits if people are having problems. Next slide. We'll be looking at a number of different instruments. As I mentioned, these will be completed every 12 weeks, currently planned on paper. Next slide. We'll also be collecting some samples for research, including measures estradiol and also of adherence. Next slide. And the endpoint will be discontinuation of the initially prescribed endocrine therapy for at least 60 days, because we know that sometimes people end up stopping for some reason, so we're trying to make it fairly liberal. Or if you switch to a different endocrine therapy, that will also count as non-persistence. But as I mentioned, we're not dictating what endocrine therapy to use, what method of ovarian suppression to use, what dose or schedule of anything to use, and we're not dictating what type of symptom management needs to occur. Next slide. We're hoping to enroll 540 patients. We would like to improve persistence by about 50% with a baseline estimate of 20% non-persistence. This is hopefully going to be R01 funded. We got a really good score, and we're just waiting for the actual notice of grant award before we can start to do things. And really that's to cover the intervention, to cover the IT support and the correlative studies. But this will be conducted primarily through NCORE sites, including the Latin America initiative, and it will be open to all NCTN sites as well. Next slide. So really in summary, we recognize that adjuvant endocrine therapy is a key component of treatment, improves disease outcomes, but it can really cause some difficulty for patients, negatively impacts their quality of life. And we expect people to take this for 5 or 10 years. And so it's very important for us to understand the mechanisms underlying the toxicity, understand why people are taking it, whether it's for toxicity or not taking it, whether it's for toxicity or for other reasons, so that we can really try to identify effective methods to reduce toxicity, improve persistence. And my final slide, next slide. So what we would like to do is try to get comments comments on what Dr. Wagner presented, comments on what I've just presented, and really try to open the discussion about what are new things we could do in SWOG that are related to symptom management trials, secondary analyses, implementation studies, or even looking at other disease types and other symptoms and other drugs. So we welcome any and all ideas. So thank you so much.
Thanks, Lynn. That was great. And we've got some time now to have some interaction. We've seen some questions on the chat, and there's a chance for anybody to make comments as well. So let me start with one comment from the chat that came from Marge Good from the NCI, and she was asking about whether there's an association with the symptoms like AIMS and the outcomes like we see in certain other instances where the people who get the most toxicity get the most benefit also. Is that kind of association seen in this case with AIMS?
This is Lynn. Henry, I can take that one first, and then Dr. Wagner might have ideas as well. I know this is developing symptoms has been looked at in association with disease outcomes on a number of the really large trials that have been done, ATAC, IES, a number of those. There has been an association between presence of symptoms during treatment and better disease outcomes on some, but not all of the clinical trials. But I will say that a lot of those analyses have been challenging because it doesn't necessarily take severity of symptom into account. It doesn't necessarily take change from baseline, or you don't know if these are new symptoms or just continued symptoms, or if they're worse than they were before or not. So the study, there's a hint there that there might be something, and certainly I try to encourage people to continue taking the medicine unless the symptoms are really, really bothering them, because there may be an association there, but I think there's limitations to the analyses that have been done previously that makes it hard to know the real answer.
So, I mean, just to sort of add on this is Dawn Hirschman. You know, I think that some of the other toxicity constructs are from short-term exposure. And one of the biggest challenges, I think, in terms of adherence and outcomes is it's a long-term exposure. And so it makes it very challenging methodologically from a research perspective to know what the best outcome is. But it also makes it very challenging to answer questions like that, because ultimately, even lower doses for a longer period of time are more beneficial from a patient perspective than stopping altogether. So I think one of the challenges, I think, in hearing both of these conversations is, do we have the best outcome for adherence? Is early discontinuation the best outcome, or is medication intake over a 5-year period the best outcome in terms of understanding what it means for breast cancer recurrence? So that's a question.
Yeah,
thanks.
Dr. Wagner, did you have anything you wanted to add to that?
No, I mean, I think those are great points.
Yeah, thanks.
And patient-reported adherence, of course, is hard to capture, but I think that's a great point.
I was thinking about how so many summary statements about the toxicity of treatment sound like this. There were no unexpected side effects, and toxicity was manageable. So I guess the point of E1Z11 in this discussion is there are some more details that you can get into to understand the patient experience. But Dr. Wagner, I was thinking about what you were telling us about this definition of tolerability and how you're looking to get kind of concrete about that. Can you see the word manageable turning into tolerable, and tolerable having an actual definition?
Absolutely. Yeah, thanks. That's a fantastic question. And we, among the consortium, talk about how this term well tolerated is thrown about a lot, accompanying adverse event tables. But we have data from the ECOG-ACRA 1912 leukemia trial, the trial that actually changed practice for CLL, for the management of CLL, in showing the value of ibrutinib. And we found a significant proportion of patients, up to 15%, discontinued their therapy due to adverse events, but they had 0. They were graded as grade 0 AEs. So there is a lot that's missed there when we simply take a look at an adverse event table and walk away, with the message without asking the patient directly that treatment was tolerable. If we just simply base that on AE grading, and especially with most trials that only grade 3 use grade 3 and higher for reporting. So I think that, the patient input on the tolerability of treatment is a key consideration here, and enhances the interpretation of adverse events by a lot. We think we have thought about the GP5 item as a patient-reported measure of treatment tolerability. I mean, I am bothered by side effects of treatment, and has shown predictive value now, in many contexts. And so, Lynn, I was thinking as you were presenting, it may be worth thinking about including that item in your assessment of patients to facilitate discussion, with providers. Sometimes if patients may be experiencing symptoms, they're not bothered by them. Sometimes they may, experience just general discomfort that's not really attributable in any one specific symptom, but that is interfering with their desire to continue, or their ability to continue treatment. So it may be worth thinking, about including that to facilitate the patient-provider communication about those other concerns which may be contributing but not captured.
So I assume that you need to do it in the 6 weekly questions as opposed to just in the every 12 weeks, because we're capturing it in the every 12 weeks. So
yeah, I think so.
So I'm going to jump in here and bring the patient voice to the table. Having been on an aromatase inhibitor for almost 10 years, I love the idea of active symptom monitoring and bidirectional communication, because I think there's so much to be learned by just asking the question, hey, how are you doing? What's happening with you? Because it may additional information may bubble up that we're not thinking about within the context of the confines of the validated instruments that we have to be using to maintain the rigor and integrity of the trial. But it may present us with an opportunity to come up with another set of troubling side effects or things that are impacting one's ability to move throughout a day. And get on with their lives and not feel like they have the breast cancer or diagnosis and treatment sitting on their shoulder for a very lengthy period of time, because these are long-term therapies. So I have to give you a shout out for including active symptom monitoring and having those discussions with patients.
I mean, I think that too gets a little bit to our desire to try to think about doing measures other than just things that may be a little bit more burdensome, getting people to answer questions, but some of these digital monitoring or like watches, the rings, all these things that we've been hearing about for monitoring, if we're able to incorporate things like that, and I realize it can be challenging in the context of a multi-site, trial like a SWOG trial, but if we're able to really measure, capture things, how is it really impacting sleep? How are people being less active during the day because they're now on a new drug? That type of thing is really, if we can capture it in a reliable but relatively low burden way, I think that's very important for us to be thinking about. And if people at different sites are doing some pilot studies looking at some of these novel data capture methods, those are things that we'd like to learn about so we can try to incorporate them into larger multi-center trials.
And related to the discussion, Mike, and back to your question about tolerability, we also have found, and I was fortunate to have had the opportunity to write an editorial to accompany Dawn's paper in JNCI to really, think through more carefully or articulate, thoughts on treatment tolerability. And we have been finding that the GP5 item, bother by treatment side effects, has the most robust predictive value in patients with previous treatment and or with comorbidities. So I've come to think about tolerability as a broader construct that is influenced by not only the cancer diagnosis, risk of recurrence, the burden of treatment, but the bigger picture in terms of other conditions, medications for other comorbid conditions. And I anticipate patients may just get to this point of treatment weariness, and when you're talking about a pill that has to be taken daily for 5 years, possibly 10, patients reach this tipping point. So I'm just especially excited about the trial, Lynn, that you're proposing as a way to, find when this happens and intervene at the point that patients hit their tipping point, but also would just encourage us to think more broadly about baseline as it's our baseline when we design our trials, but it is not the patient's baseline because they bring so much with them.
And that's such a key point. Oh, go ahead, Dawn.
I was going to say it's also important to think that, simultaneously we're learning more about ways to intervene. And, so it's sort of a moving target, because if we have things that we can act on or advise or even listening to the patient, it's a lot, it's a completely different scenario than not asking at all. And so just sort of back to what Anne-Marie was saying is just the engagement in and of itself help patients feel supported to stay on, even if they don't consider it tolerable in some way, right? So, I think knowing about which things that we can intervene on to make a difference, I think, is critically important.
Dr. Hirschman just made like a great, really great point. It's the validation. It's just being heard and being acknowledged and being told. I mean, I can still remember shuffling out of bed, but that cleared up. And because I'm like persistent with things, I said, I'm going to stick with this. And if it continues to bother me, I'll bring it up with my doctor. But by the time the 3-month appointment came, it had resolved itself. Now, another person, so this is where being able to communicate that to a patient to say, maybe it will clear on its own, but if it doesn't, we will discuss measures. I'm just asking you to please stick it out for a month or stick it out for 5 weeks. And just that validation, I think, goes a long way towards goodwill between we're throwing medication at you and we expect you to do this, as opposed to we want to acknowledge that certain things may or may not happen. And if they do, let's talk them through. So I thank the entire team for being so patient-centric. I know that's the big buzzword, but you guys are walking the walk. So thank you.
Yeah, that's where this notion of tolerability and, where the individual is vulnerable and what their baseline situation is. Do you have to shuffle your way to take care of somebody or go to work to be able to pay your rent, or how much time do you have to work through the side effects, different vulnerabilities for different groups. And so I noticed Dr. Huang and Dr. Berenson and others talking in the chat about the enrollment of these different racial ethnic cohorts, and particularly the Asian population, noticing that they had different vulnerabilities than some of the other populations in terms of diabetes, obesity, and a little different prevalence of the symptom. So, I was wondering about, Dr. Wagner, your feelings about having designed it very uniquely that way into these fixed cohorts, which allowed those questions to be answered. So it's like, glad you did it, but also dragged out the enrollment, right? This thing crossed the finish line so slowly. So I can imagine this mixed appreciation for that design. You got really important stuff, but you aged in the course of the study.
Right.
And maybe what advice you would have for Dr. Henry about how to enroll diverse cohorts and what you would do in the future.
Well, and that's a great point, because in the time that from the time that was designed to the time we started looking at the results, additional candidate SNPs were identified, but because we did not include that in our primary outcome, those analyses will have to occur, in the wave of secondary analyses. Absolutely. And I'll be honest, I think I would say that we did things later on into the trial that we should have done in the first place, in terms of engaging breast cancer advocacy organizations specifically for Asian women with breast cancer. I mean, Asian breast cancer is less prevalent among Asian women. So we anticipated going in that would be a tough group, a tough cohort to fill. And it was ultimately our collaboration with some advocacy organizations that helped us to promote the trial, that helped us to get over, and Victor Chang, our colleague from Mekai Akron, helped facilitate those connections. We're now using the same approach with TMIST to try to be more proactive. Yeah, absolutely. There was also a question. Oh, go ahead.
Oh, just go ahead, finish. I'm sorry. I was going to ask, how you incorporate in, when you're thinking about biologic predictors, how to incorporate in social predictors into the same scenario, and are we paying enough attention to collecting information on social determinants of health in all of these unique patient populations?
Dawn, absolutely. And I wanted to add also, we just recently have results from TAILOR-X accepted for publication, where we found that insurance status and neighborhood deprivation index were predictive of early endocrine therapy discontinuation. So we really need to embrace a broad view of tolerability to include the social context and the socioeconomic context, from a patient's perspective. And Mike, the example you gave is a great illustration. If a patient has to choose between taking her AI versus being able to function to get to work, that really may be the driver of a decision in terms of being able to tough out side effects versus, needing to discontinue so that she can maintain her employment and insurance.
So I know Hildy just put a note in the chat that we can see asking, were there strategies that worked better to accrue Asian Americans? I know you mentioned talking with advocates, but she said, such as having an Asian American research professional to introduce the study and address concerns, or even any other things. For the 2010 trial, we've thought about ways to try to increase Hispanic participation. We're going to have it open at Latin American sites that are affiliated with SWOG, and have reached out proactively to all of the NCORE sites, including those that see a high proportion of underrepresented minority as well as rural patients. And so, but I'd be interested to hear both for the African American population, also for the Asian American population, if you had any additional tips that would be useful across the board. I mean, all of our trials need to be more diverse than they are, and so, or need to enroll a more diverse patient population, and anything that you can suggest would be welcome.
Sure. Oh, well, thanks. Thank you. And I'm speaking in part on Jeff Berenberg's behalf, because the University of Hawaii has done a phenomenal job with TMIST in implementing a great model of community engaged and community-based participatory research in employing lay health advisors and community health educators at their very large and geographically expansive affiliated network. So, I mean, I think, that was a very strong theme in this year's NCI NCORE annual meeting, which is the importance of, building trust in local communities. That's very hard to do as a centralized research team like SWOG, like ECOG ECRN. So I think our collaboration, with NCORE sites and their local networks is critically important to try to promote that familiarity. I mean, it's, there also is a lot of discussion about racial concordance and whether racial concordance is important for quality of care, as well as clinical trial participation. It may be that a racially concordant provider or a racially concordant navigator may be more successful at overcoming barriers to participation, such as medical mistrust. I mean, certainly that's the case. We know that medical mistrust is more prevalent among Black patients when it comes to enrolling in trials, specifically looking at genomic data. So these are important considerations. I think at the end of the day, my takeaway, but I certainly welcome others' input, my takeaway is that we're still just not offering trials to minority patients as frequently. And when the provider, that trusted provider, presents a trial and encourages a patient to enroll, that's our best strategy. But understanding that's challenging for resource constrained sites. And it takes longer too. These discussions take a lot longer for patients who have to overcome social determinants of health and other SDOH related barriers to participating. It's a complex problem. Spoken like a true psychologist, right?
Yeah, you can imagine the more vulnerable patient, for whatever reason, maybe not being offered a trial because you're worried that they're more vulnerable and they won't, they're more vulnerable to missing their follow-up appointments and getting missing data, right? Or whatever your story in your head is about why some person is a better candidate for a trial. And I think some of those might be implicit kind of considerations that we, aren't always aware of, that we might be vulnerable to making.
And there was also there was a question in the Q&A about whether the lower rate of discontinuation that we observed was likely due to it being a trial population more closely followed. I think, yeah, absolutely. I think that's a fantastic observation, and would agree also that our very restrictive eligibility criteria probably set the sample up to be more likely to be able to continue their AI therapy. We excluded people who came in with comorbid conditions and with pain, so that we could be more confident that any newly emerging pain was due to the AI therapy. But as a result, we probably excluded patients who had a greater vulnerability to discontinuing because they already had pain due to arthritis or pain due to other conditions that then may have been worsened with an enhanced vulnerability to discontinuing.
I'm just wondering what, we sometimes for these trials, because power is such an important issue, we include, switching. And switching AI as an outcome is probably a measure of lack of tolerability. Do we know that that's associated with discontinuing over time, or any other marker for poor outcome on that level as well? Because I know that was a big, that was one of the endpoints in E1Z1-1. Even if you stopped, but you started another treatment, it was counted as an event, right?
Mm-hmm. Yeah, that's a great question. That would be that's on our radar for analysis. So it certainly will be interesting to look at whether a patient who switched their AI, the rate of persistence then on that AI.
Mm-hmm.
Well, one last comment here. So Dr. Wagner, E1Z1-1, the landmark trial, you've got just an absolute ton of data to go through and deliver on. How do you guys as a research base figure out how to deploy the right people, enough people to sort of learn what needs to be learned from the data that you've already collected?
Yeah, absolutely. That's a fantastic question. So we, now that the primary results have been reported at ASCO, we're working, Vered Stearns is working on the primary manuscript, but I've talked with Bob Gray about this, and we plan to send out a solicitation to the full study team. So this would include you and Lynn Henry and others to solicit ideas for future papers, future analyses. And we're very lucky to have UO1 funding, Cancer Moonshot funding, to support dedicated statistician time, both ECOG Akron statisticians at Dana-Farber, as well as a team of statisticians at Northwestern and at Wake Forest for the application of innovative statistical techniques to understand the adverse event data, the discontinuation data, and our patient-reported outcomes data. So I would say once that primary paper gets out, we'll be able to share that data with our teams, and then we'll have a great resource in terms of analysts available, and we'll be looking for colleagues to partner with us in leading those papers and analyses.
That's great. So for people on the call who may have an interest in exploring certain aspects of this study, it's a good time to bring your thoughts and your energies forward, and when the time is right, there'll be a process for how to get engaged. So thank you for that, and Dr. Henry, you guys did a great job in this symposium portion of our meeting. So so now we'll transition to the next part of our meeting to talk about active trials. If you can bring up the next slide there, right? And the first one on the queue is S1600. So I think that'll be the next slide. And so Dr. Jill Hamilton-Reeves is the PI of this trial, and Dr. Hamilton-Reeves wasn't able to join us today, but just to go over, the objective of the trial is to determine the impact of a perioperative immunonutrition intervention versus ordinary nutrition in terms of postoperative complications after radical cystectomy for bladder cancer. And so this study has now accrued actually 108 patients of 200, the target enrollment, and is going well. It got reactivated in May after there was a temporary shortage in the immunonutrition intervention drinks, but that got resolved. And there's been some protocol updates related to some translational piece in terms of collecting stool for microbiome studies, which are very much of scientific interest these days. and it's now eligible to Spanish-speaking patients as well. And there's a few other general clarifications in the recent protocol changes. So this is going very well, and more to follow on that one. Next. So Dr. Jessica Huang is with us, and Dr. Huang, do you want to update us on SWOG 1614, which is going through its own reactivation? You may be on mute. Dr. Huang, are you with us? There, I see you.
Hi, I'm sorry, I just stepped away.
Okay.
Thanks, Mike. Apologies for being late. I just wanted to really thank everyone for continuing with us on this protocol. It's been a really long journey, and it's been reactivated. So today I'm thrilled to tell you just a little bit more about it. Next slide, please. So it's my great pleasure to remind us all about the new recommendation from ASCO from 2020. ASCO now recommends universal hepatitis B screening. It's depicted here. There's 3 tests, the surface antigen, the core antibody, and the surface antibody. And if the surface antigen or the core antibody is positive, then these patients need further evaluation. This is really all to prevent patients with cancer from having very terrible liver outcomes if their underlying hepatitis B status of infection is not determined prior to the initiation of anti-cancer therapy. In the panel recommendation, interestingly, they recommend that large randomized studies are needed to determine optimal strategies, management strategies in patients with solid tumor, where there is very little data to offer solid recommendations. Next slide. And so I just show you the schema. This is an updated one because of the new antiviral therapies that are offered in this protocol. All solid tumor patients who have already been screened and found to have chronic or past hepatitis B and are anticipating anti-cancer therapy, whether it's cytotoxic, targeted, or immunotherapy, would be enrolled into one of these 2 cohorts. Cohort on the left are those with a positive surface antigen. Those are those who we consider to have chronic infection. They would be randomized to either arm 1 or 2. Arm 1 would be the initiation of prophylactic antiviral therapy with either entecavir, tenofovir, alafenamide, or tenofovir disoproxil fumarate. Arm 2 would only start, these patients would only start one of these antiviral therapies if they developed hepatitis B reactivation. If a patient was found to have a past hepatitis B, that would be cohort number 2 on the right, they would be randomized to arm 3 upon indication, as we just mentioned, or arm 4, which is usual care, whatever the physician and the study team usually does at their site. Next slide. So those are just the highlights. And if you have any questions or would like some guidance, we work very, very closely with each of the sites to bring on patients and to answer all questions as quickly as possible. Please reach out to me or my co-chair, Anna Locke. Of course, the SWOG stats group cancer control question at crowd.org are available. And for more information, the protocol and revised is updated and available on the CTSU website. Thank you.
Thank you so much, Dr. Wong. And I haven't seen anything come through the chat. I do want to encourage that if you have any questions about any of these studies that we're going through, please feel free to speak up. And in particular for S1614, it was closed for quite a while and had a very major revision. And so we do want to encourage all the sites to please take a look at it. Consider opening it at your site if you haven't yet. With the new ASCO guidelines related to screening for hepatitis B in patients with solid tumors, not just those with hematologic malignancies, as we are starting to implement those workflows in terms of routine screening into our patient populations, this trial may become more relevant and more attractive for participation. And so we definitely encourage everyone to take a look at it and to reach out to us with any questions, concerns. If you're not sure if you want to open it, we're always happy to talk with you. So thank you. And so next we're going to turn to 1714. This is our prospective observational cohort to develop a predictive model for CIPN. And it is being led by Dr. Trivedi.
Hi, everyone. Thanks for inviting me to give a quick update on S1714. The study's been accruing really well, and we're actually very close to closing the study. We anticipate it'll be closed by the end of the year with completing accrual to this increased enrollment, potentially even within the next month. So thank you to everyone for supporting this study, and we're looking forward to starting the analysis.
Yes, thank you very much. This is another example of one of these longitudinal observational cohort studies like E1Z11 that we heard about earlier that can be really instrumental for learning a lot about mechanisms underlying toxicity. And so thank you to everyone for supporting it thus far. We're really in the home stretch in terms of finishing up accrual, most likely by the middle to end of November. And we look forward to sharing the results once it's analyzed. Next slide. And so this is S2013. This is our most recently activated trial. And I am going to turn it over to Dr. Ginturu to briefly talk to us about the different aspects of this new trial. Thanks.
Thank you, Dr. Henry. It's great to come back to the home team after the study is activated. Next slide, please. So we all have been treating immune checkpoint inhibitors in the clinic, and we also noticing immune-related adverse events. What we are looking for more information is how these IRAEs, sometimes which are unpredictable, how they occur and what are the risk factors to develop these IRAEs. So this study is designed to collect the longitudinal information on immune-related adverse events and also patient-reported outcomes in daily practice to identify patients at risk. Next slide, please. So this is a prospective observational study. The goal is to develop and validate the risk prediction model for CTCAE grade 3 or higher non-hematological IRAEs in the first year of immune checkpoint inhibitors for patients receiving treatment for any of the solid tumors. Next slide, please. So the secondary objectives, what we're trying to look from this study is to not only look at the higher grade toxicities, which is mostly reported in the clinical trials, and also look at the low-grade toxicities, which are bothersome for the patients who are going through the treatments in the real life, in the regular clinic every day for us. So we're planning to assess the incidence of any grade non-hematological IRAEs and grade 4 hematological IRAEs for patients receiving ICI therapy. We're looking at the patient-reported quality of life and patient-reported adverse events by PRO CTCAEs, because sometimes we may think as, oh, okay, the rash is grade 1, and patients are the one who are going home and not able to sleep because they're up all night long with itching. So we do not count and report all of those in the clinical trials. So our goal from this study is also to look at these chronic grade 1 and grade 2 toxicities and get perspective from the patients. Next slide, please. So this is the simple schema of the trial. So once patients are consented and registered, they'll undergo baseline evaluation per their treating oncologist, and they'll receive immune checkpoint inhibitors. So that's a standard of care treatment per the treating oncologist. Once they're enrolled in the study, they will fill out initial information, and at week 4, 12, 24, and 52, we'll do evaluations, which I go into detail in a second. And also at grade 3 or higher toxicities, when it happens, they get evaluated. So this study is for total 52 weeks, which is 1 year, and that's when patients complete this trial. Next slide, please. So the main eligibility is for any solid tumor patients receiving ICI for FDA or NCCN category 1 or 2A. Main thing is not to participate in another clinical trial. I'll talk about Alliance trial in a second. And they should be receiving ICI alone or in combination with another ICI. So they should be able to fill the PROs in English, Spanish, or French. They should have recovered sufficiently from the prior treatment side effects. If they're receiving chemotherapy, biological, or targeted therapy in combination with immune checkpoint inhibitors, they would not be eligible for the this clinical trial, S2013. Next slide, please. These are the top 10 key immune-related adverse events that we're collecting, which goes from myocarditis to hematological toxicities. Next slide, please. Also includes endocrinopathies, others too. Our goal is to accrue 2,000 patients, which comes to 57 participants per month. And this is a hefty goal. And so far, 4 patients are enrolled to date. And we're also proactively involving NCORE sites and with the SWOG Latin American Initiative for diversity and inclusion. PROs are also in Spanish and French in addition to English. Stratification factor is from monotherapy versus combination of immune checkpoint inhibitors. Next slide, please. This shows the top study calendar. We can go to the next slide. I'll go into the details. I'll break it down. So main thing for the pre-registration would be to people will consent and they'll register. At that time, they'll undergo their regular treatment and the lab. Before they start the ICI, we also get information on their concomitant medications, also comorbidities. They'll get the baseline labs, they fill out the PROs, and then they'll get ICI. They'll get, in addition to that baseline, they'll also get evaluated at these 4 time points at week 4, 12, 24, and 52. Where we get information about these other medications, CTCAE, PROs, they'll be collected standard labs for the treating oncologist. They would also get another blood for banking at week 4, in addition to the pre-registration, the registration before they start ICI. If they develop grade 3 or higher IRAEs, then we would be collecting blood at that time, along with the PRO CTCAEs. One thing I would like to stress in this is, even though these are the 4 time points, we encourage sites to assess CTCAE in between. So that way we know when they develop grade 3 or higher toxicities, then we would be able to know exactly when they would develop this. So all of these assessments will continue even if the ICI is discontinued. Next slide, please. So when the serious adverse event happen, we encourage to collect blood prior to starting IRAE treatment, such as steroids or immunomodulatory drugs. If it is not feasible to get before they start the treatment, at least to get the blood collection and report what time frame in relation to these side effects that the blood was collected. Patients also fill the PRO CTCA form, and there is a S2013 IRAE form. We encourage enrollment into Alliance trial at the time of grade 3 or higher IRAEs, which is complementary to S2013, as that trial is looking more about when people develop side effects. Next slide, please. So this is the translational objective of the study to evaluate the cytox score, which is a composite measure derived from 11 different cytokines. And the other objective is to establish a repository of archival tissue, which would be collected at baseline. They don't need to undergo a new tissue biopsy. If they have a prior biopsy, that would be enough for the study. And they'll also get the blood and plasma specimens to predict our prognostic markers for the IRAs. Next slide, please. So this is the plan for the blood specimen for banking. So the 3 time points, mainly 2 time points, and when suspected IRAs, and also existing the tumor specimen. Next slide, please. So this is a study for all patients who are getting ICI, who are not going on the clinical trial. We have a lot of these patients in our everyday clinics, and we're hoping that you would enroll, open this study at your institution, and also enroll more patients so that we can get to that 57 people, patients per month accrual. Next slide, please. I'd like to acknowledge my S2013 team for teamwork and getting us together. And I would also like to give a shout out to our digital engagement team, who is working on our plain language and the social media kit for this clinical trial. As you have seen in the other slides, iCheckIt hashtag is what this study is going to be. That is going to have a Twitter tweets with iCheckIt, focused towards our patients and also towards our providers. So I would like to welcome any questions and also ask my study co-chair, Dr. Hirschman, or rest of the team to comment on.
Yeah, thank you so much, Krishna. There is one question in the chat that says, are immunotherapy drugs contraindicated in patients with elevated bilirubin levels?
So it is, if the treating oncologist feels that they are able to undergo ICI treatment, then they would be eligible for the trial. So if that is the question you're asking.
Yeah, so I think that theme is important, and we've tried to design this trial to make it as simple as possible. And so really it's patients who the physician believes are a good candidate for treatment with ICI. It doesn't matter if you have, lab abnormalities, or if you have brain metastases, or if you have an autoimmune disease that's pre-existing. If the doctor thinks that this person is an appropriate candidate and they're not participating in a treatment trial, and they're not getting concomitant chemotherapy with it, then we want you to think about this trial. And really all of the assessments are designed to be lined up with when patients would be coming in anyway. So the baseline is when they're starting, and the 4-week assessment is designed to line up with cycle 2 with some leeway depending on the length of the cycles. And as Dr. Hirschman mentioned in the chat, we're including electronic PROs after baseline to try to make it as easy as possible to get those completed as well. So we designed this sort of as a pragmatic trial. We're trying to make this as easy as possible for sites. And so certainly if you see anything that's unclear or you're not sure, please feel free to reach out.
So they would be, as Dr. Henry mentioned, patients will be picking, the initial one is the paper PRO. After that, they have a choice to pick whether it's a paper or ePRO for the rest of the study.
And so here's a question that came through the Q&A. Are we collecting tumor response RECIST and obtaining central imaging?
No, we are not. This is mostly a risk prediction, and we're looking at the patient-reported outcomes, symptoms. So this is more focused on the other side of immune checkpoint inhibitors, IRAs.
Yeah, we anticipate that the participants in this trial would be too heterogeneous for us to really be able to look at disease outcomes. So we're focused very much on the drugs and the toxicities, but that's a great question. Other comments from any of the other panelists or anyone else through the chat?
I would just comment briefly that in terms of the social media toolkit, connecting it to the discussion at the symposium, we should pay attention to making some directed messages that are tailored to specific groups of patients. So the messages that work may not be the same for every group of patients that we wish to enroll.
And Dr. Hirschman, I saw your hand up.
Yeah, thanks. So I would also say to anybody out there that has ideas from their institution or pilot work on risk prediction models or biologic or clinical factors that may be associated with risk, this may be an opportunity in the future to both even think about this for this trial or for the CIPN study of secondary studies that can be done to be built off of these trials. And so, now's the time to sort of put on your thinking caps to try to get that preliminary data, even Hope Foundation funding to do things at your own institution that then you could maybe validate in these larger cohorts.
Very good, thanks. Oh, I see. And any other comments from anybody?
I think there is another question, Dr. Henry, from Dr. Rowan. I would be very interested in evaluating body composition and risk of IRAEs based on standard CT images collected as part of the routine care. So I think it. So in this trial, we're not planning on getting the CT images. I'm sure we can think about it for the next trial. Welcome your ideas.
Well, but
I think that's really a great, oh, sorry, go ahead, Lynn.
Yes, I was going to say the same thing. I appreciate the comment from Dr. Rowland, and this is exactly the type of thing that we're interested in, because there's definitely a precedent for trying to collect imaging off of other ongoing trials, thinking of mammography in S1418 and things like that. And so, this is something that we could try to build in maybe for a subset of patients. And so we certainly are interested in having a conversation offline about whether or not we can include something like that and what the cost would be. And so, we do welcome ideas that are either for secondary analyses that can be performed after the fact, or for things that maybe we do need to think about including in real time, but perhaps only in a subset of patients, depending on the level of burden for the patients or the cost. So thanks.
Yeah, I was going to say that's a perfect example of a secondary analysis where you can go back and collect the data. I think it's important to talk about it now to think whether or not you need to collect it prospectively or think of it as a nested case control amongst patients that do develop toxicities. It may be harder to go back and get the scans after the study's done. So I highly encourage you to discuss, with Lynn and Mike and Krishna, the possibilities of building in a study like that.
There's also a comment in the chat box from Hildy Dillon, which is kind of interesting, making the observation that dropouts with grade 1 to 2 adverse events are usually dismissed as an accrual issue. So that, that's something else to look at, although this is in real world treatment, not within the realm of a clinical trial. So you're going to be collecting data up to a year out, even if the patient stopped taking the ICI, correct? Just to clarify. Yeah. Okay. Thanks.
That's right.
Well, thank you very much. We're just getting started on this trial. So as things come up, if you have questions, if you notice things in the protocol that are unclear, please don't hesitate to reach out. And we look forward to hopefully providing, very encouraging updates as we go along at each of our subsequent meetings. So thank you in advance for your support for this trial. So next we're going to turn to concepts under development. Next slide. And one more. Thank you. And so this first one is a study from Dr. Kubo. She's talked to us a little bit about it before, and we wanted to invite her to give us some updates. I know I saw her on earlier. I don't know if she's still there.
I'm here. Can you hear me?
Yes.
Okay. I don't know. The camera looks a bit blurry, but thank you for having me. This is a really quick update on our concept, mHealth mindfulness to improve quality of life of metastatic prostate cancer patients and their partners. Our primary aim is to investigate the efficacy of 6-week mobile-based mindfulness intervention to improve quality of life compared to active control group, which is another app that delivers relaxing sounds, nature sound, for 6 weeks. And we will be measuring outcomes at 6 and 12 weeks. As secondary aims, we are looking into the efficacy of intervention on anxiety, depression, relationship satisfaction, and fatigue on patients, and as well as on the romantic partners. As exploratory aim, we will be looking at the mediation by mindfulness and interdependence between caregiver of partner and patients, because it is said that when partners' well-being improve, they can better take care of the patients. So there's a interdependence between the two in order to improve quality of life in both parties. Next slide, please. So this is a list of eligibility criteria. We are looking for a patient with metastatic castration-sensitive prostate cancer patients without clinical evidence of disease progression, initiated androgen deprivation therapy, no use of cytolytic chemotherapy, adult patients with English or Spanish speaker with baseline distress thermometer of 4 and above, ECOG of 2 or lower, and no current regular meditation or mindfulness. And we actually changed the definition as 3 times or more per week of regular practice. Next slide, please. And here is a treatment and schema. We are doing individual level randomization, and the intervention participants, they will be randomized as a dyad. So both patient and partner will get the same intervention, and they will be using the app independently. So it's not like they will be listening together. They will have specific login for each person. 6 weeks for 10 to 20 minutes a day. So intervention will use Headspace app, and control will use an app called Nature Space. This is to control for participants' ability to use technology, and also to control for the attention and duration of the attention for these apps. And as I said, we will be collecting data at the baseline and right after the intervention, and 6 weeks after the end of the intervention. And we will be looking at quality of life, anxiety, depression, fatigue, relationship satisfaction, as well as mindfulness. Next slide, please. We are hoping to enroll 376 dyads, taking account for 20% dropout and 5% ineligibility. And we submitted this R01 last October 2020, and it was unfortunately not discussed. So we just submitted in last week with different study sections. So we are hoping that this will have a bit better outcome. And we would love to hear any questions or suggestions about this. I think this is the end of my presentation.
Yeah, thank you so much. And while we're waiting for questions to show up in the chat or the Q&A, I think this is a great example of symptom management intervention approach for an important patient population. You know, patients with metastatic cancer, you know, are often able to be on different therapies for a prolonged period of time, and they can definitely have a number of symptoms either related to the cancer or to the therapy that really should be intervened upon. Yet most of the studies that are out there for symptom management have focused specifically on patients with non-metastatic disease. So I think this would fill a very important role and serves as a really good example of different patient populations to think about in terms of symptom management. It also highlights different ways we approach funding the trials. So this one and the 2010 study that you heard about earlier are both ideally going to be R01 funded, as opposed to the iCheckIt study, which is funded just through the usual DCP mechanism. And that contrasts in a third way to the next study that we're going to hear about, which is related, which is hopefully going to be at least partially funded by a device company. So there's a lot of different ways to approach trying to conduct trials like this. I know that Dr. Genturu has her hand up, and I'm going to ask first. Dr. Berenberg asked, is it cluster randomized?
It is individually randomized.
And then another question from Samantha Wright is, do you plan to have any availability for phone loans or something for people that don't have access to a smartphone?
Yes, for the last submission, we didn't have it, and it was a part of the eligibility criteria to have a smartphone or internet access. But for Dr. Henry's suggestion for this round, I have incorporated that as a part of the plan. So if anybody has need for loans, we will have it.
Great. That's important for being able to have it available to as many people as possible. Dr. Genturu.
Dr. Kubo, this is a great study, and I'm so glad to see a clinical trial on this one. My question is regarding the intervention arm in the headspace. There are multiple components of headspace, whether it's from anxiety to even presentation anxiety, all of those. So is there a specific that they're going to, participants are going to follow for this trial, or is it anything general in the headspace realm?
So that's a really good question. We go back and forth with different options. I've been studying mindfulness for cancer patients for a long time. And when we started with a pilot study, patients wanted something that was more particular for cancer journey. So I requested to Headspace, and they did make PAC, the 30-day program for particularly for cancer patients or families of cancer patients. So we can specify, we can have a specific program where they would do 10 days of basics, and they can do 30 days of cancer specific up. But so far I have been letting patients or participants decide, because everybody has different needs. Some people may want the sleep package, and some people have more anxiety. So we usually give them a few suggestions, like we would like you to choose from these 5 options, because sometimes it's overwhelming to have 20, 30 options. So I think we will go with that route, because people really like the option to be able to choose, and we can get the data on who used which app, so we will be able to see like if there was any differences in the effect size, depending on what app they use for different outcomes. But I think that's the way we go. But we are flexible. We could make it completely specific for the study, and everybody will have the same exposure. I think there are pros and cons of both approaches.
Great, thank you. So these are definitely discussions we can continue to have over time, and good luck with the grant submission. And so next we're going to turn to our the final concept in development at the moment, which is being led by Dr. Melissa Acquadino. It was recently approved by SWOG Triage, so it has a number. It's 2205. So Dr. Acquadino.
Thank you, Lynn. So this is our new study, 2205, or Stop CIPN, which is hopefully going to expand from MAGNA study And this is an interventional trial with cryocompression therapy versus continuous compression versus low cyclic compression, which is going to serve as the control arm. And if you can go to the next slide. So just in terms of a brief background, we know that CIPN is common. It is dose limiting. It can have humongous quality of life effects. We know that there are really no known prevention for CIPN. There have been many trials, some of them done in SWOG, that have looked at different agents for prevention, and almost all of them have been negative, and some of them have actually caused harm. Small studies have shown that cryotherapy and compression therapy could be effective, but they have not been randomized. We recently completed a phase 2 study at Columbia, and our preliminary results show that compression therapy compared to cryotherapy compared to placebo, that compression therapy had the highest probability of preventing CIPN in a larger phase 3 trial. This was not, there was no hypothesis testing in this trial. This was an adaptive design trying to find the intervention with the highest probability of success in a future trial. And we think the reason that compression therapy prevailed over cryotherapy, which was done with frozen gloves and socks, was that there was poor tolerability to the cold arm, and patients really didn't tolerate it. And you can see that in terms of adherence, compression therapy was really well tolerated. 80% plus were able to adhere to all cycles of their treatment, whereas only about 30% were able to adhere to cryotherapy. So the thought is that cryocompression therapy, combining both pressure with cold, can overcome limitations of cryotherapy alone and can make it more tolerable. So our hypothesis is that cryocompression therapy or continuous compression therapy in this larger phase 3 trial will be effective at preventing CIPN compared to control. And because it's going to be impossible to blind participants to their study intervention, they're going to know if they're getting cold, they're going to know if they're getting compression. We're going to actually blind them to the study hypothesis, because all of these interventions are considered having potential to prevent CIPN. If you can go to the next slide. So in regards to eligibility, we're trying to make this as open as possible. We want as many patients to participate as we can, and we're not going to define it based on cancer type, but we're going to define it based on chemotherapy regimens. So we have 4 eligible chemotherapy regimens. They're weekly Taxol times 12, weekly Taxol times 12 with concurrent carboplatin, paclitaxel carboplatin Q3 weeks for a total of 6 cycles, or docetaxel carboplatin every 3 weeks for a total of 6 cycles. And any of these regimens can be combined with Herceptin, Perjeta, pembrolizumab, or any other biological therapy. So we're hoping to get, we're hoping that this includes many patients who are treated for breast cancer, also GYN cancers, and also potentially lung cancers, or other, really any cancers that get these regimens. And then patients must be able to complete PROs in English or Spanish. Exclusion is going to be pregnant or nursing patients, those who have open wounds or ulcers who can't wear the garments, those who have Raynaud's or peripheral arterial ischemia, where it might be dangerous, especially the cryotherapy arm, and those who have a history of peripheral neuropathy or have been exposed to chemotherapies that can cause CIPN in the past. Next slide. So here's the schema. Again, we're trying to keep the eligibility as open as possible. It's going to be 1-to-1-to-1 randomization to the 3 arms. There's the cryocompression arm, the continuous compression arm, and the cyclical low compression, which is going to serve as the control. I believe in the next slide, I have a picture of the device, which is going to be provided by Paxman, and it should make a little bit more sense once you see it. The primary endpoint of the study is going to be an absolute increase of 8 or higher on the ERTC CIPN-20 sensory subscale at 12 weeks. And then we have a number of secondary endpoints, including differences in CIPN-20, which is at continuously at 12 weeks, and then also changes in promise, changes in CIPN at number of time frames, including all the other subscales of the CIPN-20, CTCAE, objective sensory motor function tests. These are the same that were used in 14.8, not 14.8, 17. I get the numbers confused. The cohort CIPN study that is led by Magna Trivedi. They're the same tests. So sites that have already done the training, hopefully should be already trained and have the materials already. We're also going to look at tolerability and patient satisfaction with the device, because we know that's really important. If it works, that's great, but if it's awful for patients, that's not something we want to use in clinical practice. We're also going to evaluate nail toxicity, as that's another issue we see commonly, especially with taxanes, and looking at dose reductions, delays, or discontinuation. And you can go to the next slide, please. So in regards to the interventions themselves, the cryocompression therapy, the device is going to go over the hands and the feet, and it's going to be at the lowest temperature of 11 degrees Celsius. If patients are not able to tolerate this, it can be raised to a maximum of 22 degrees Celsius. And in regards to the cyclic pressure, it's going to range between 5 and 15 millimeters of mercury. And there's going to be cycling of 5 minutes between the low and the high, inflation and deflation. These are kind of like the devices that are used in the hospital to prevent DVTs. They're similar to that in regards to the compression. In the continuous compression arm, there will be no cryotherapy, so there'll be no temperature adjustments, but the pressure will be higher and it will be continuous at 25 millimeters of mercury. And this is based on our preliminary work from our phase 2 trial. And then the control arm is going to be low cyclic compression. So again, there's going to be no cold, and it's going to have the same pressure variation in the cryocompression arm. And remember, for the cryocompression arm, the pressure is really to make the cryotherapy tolerable. The pressure itself shouldn't be leading to substantial CIPN prevention. So that's why this is chosen to be the control. And you can go to the next slide. So here's what the device looks like. So Paxman, as you may know, is a device that is well known for scalp cooling, and they have a successful scalp cooling product. So their device is a take on that. And instead of going to the scalp, this is going to the hands and the feet. And the device can deliver both cryotherapy, cold therapy, and also compression therapy. And there are wraps for the hands and the feet, and they have different inserts. So it's possible for patients who can have an IV in the same arm, and the IV can be used safely. And that is something that you can visualize with panel C. And if you can go to the next slide. So in regards to the next steps, this has been approved by the SWOG Executive Committee, and there should be, I made these slides a little bit early. So we did submit this concept to DCP about a week ago or so. Sorry, I just got back from vacation late last night. My mind is still all over the place. I don't know what day it is. And we have submitted paperwork to the FDA to determine if we need an IDE. And we've already started the contract discussions with Paxman and SWOG. And open to any questions or suggestions.
It's really great, thank you. One question that has come in is whether or not you are excluding patients with diabetes-induced neuropathy.
So any existing neuropathy will be an exclusion because it will be cloudy. It doesn't matter the etiology of it. So if it's diabetic neuropathy or neuropathy from another reason, those patients will be excluded.
And another question that has come in is how many devices will sites receive?
So this is because it's going to be device limited. We are thinking that this is going to be a limited institution. I believe we said 25 or so sites, and there's going to be somewhere between 3 to 6 devices at each site to allow for, number of patients to go in at once. And also in case of device malfunction, we're hoping to get sites that were high accruers to the CIPN prospective cohort study who've already been trained in how to do the sensory and motor function testing and have experience with this. But those are the next steps to be ironed out. And the I see a question about the intervention. This is going to be done in the clinic, in the infusion center. It's going to be very similar to scalp cooling, except instead of cooling the scalp, it's going to be cooling the extremities. It's going to start before chemotherapy, and it's going to continue up to 90 minutes post chemotherapy. And patients can do scalp cooling and this at the same time.
And so related to that, someone has asked, have you heard from patients that they are uncomfortable using this device around other patients, if they're visible in the middle of an infusion room?
We have not heard that. So again, we did a phase 2 adaptive design study with about 60 plus patients. Again, they didn't use this particular device, but they had wraps on their hands and their feet that were very noticeable. And we had all kinds of complaints about many, many, many things. Again, this was done during COVID as well. And uncomfortable around other patients never came up from that.
And then the final question is, if an institution already has Paxman for scalp, can they use the same device for this study?
No, it's a different device. The scalp device is not designed to deliver the same technology to the hands and the feet. But you can use the Paxman for scalp cooling at the same time, or you can use Digitana, or you can use any of the others for the scalp. But for the extremities to prevent CIPN, it's only going to be the Paxman experimental device.
Well, thank you so much. I know there may be people who have some other questions, so please feel free to reach out to Dr. Accordino. Her email is on the slide with questions, suggestions, comments, anything you see as potential barriers, because we like to know about those sooner rather than later. And we have 2 minutes left, I think. So I appreciate everyone sticking it out to the end. Last but not least, we would like to give some time to our patient advocate to provide us with some thoughts. Obviously, she's provided us with great perspective already during this session. And any final thoughts, Anne-Marie?
Just thank you for letting me keep Amy's seat warm. And I just want to share with everyone, we do have new community advocates. The first ones were brought on at our last in-person meeting. Feel free to reach out to them. I'll read them quickly. We have an AYA, rural, LGBTQ, an Asian Pacific Islander, Latinx. That's Eileen. She was on the team. I think she was the first one announced at our last in-person meeting. We have someone that represents older adults, military veterans, and we're trying to fill for advanced cancer, African American, and the caregiver roles. As we seek to increase diversity in our trials, the community advocates can be a great resource for anyone that's developing a trial. And consider incorporating wearables and sensors into the trials to get a real robust picture of what's happening in between the clinic snapshots. So you're getting the full movie of the person's life. Because lots go on in between the visits. And that my hat's off to everything that I saw today. I think this is really wonderful and very much in line with keeping the needs of the patient forefront. So I thank you all for that.
Well, thank you so much. Thanks to all the presenters. Thank you especially to Dr. Wagner for coming and providing us with insights about her experience with the ECOG-ACRIN trial. Thank you to all of the presenters who have been talking about their current and upcoming studies. And we still encourage everyone who's out there, if you have any great ideas, please come to us. We can talk about them and figure out the most appropriate next steps. So I hope everyone has a great rest of the SWOG meeting.
Take care. Thanks, everybody.